Thank you all for your patience. I was having some technical difficulty. The worst fear of any speaker is you've sent the wrong slide set. I did, and we were able to go back and get the one I wanted, but we had some trouble, so I do apologize. So today I'm going to spend a few minutes talking about chronic kidney disease, evidence-based practice, nutrition-based practice guidelines. Predominantly, I am going to speak about what the Academy of Nutrition and Dietetics have done along in this body of work. However, I want to tell you, anybody who works in kidney disease, renal disease, kidney failure, there are so many practice guidelines worldwide. There's the National Kidney Foundation out of the United States that have practice guidelines, including nutrition guidelines and how nutrition fits into many other guidelines they've published. There's the KDIGO guidelines, which are the international guidelines, and those are just started a few years ago, and they will continue to add body of evidence. Canada has them, British has them, Australia has them, and so this is, because I'm from the US, more what we've recently done, and I was also the chair of this practice of this group that went through and evaluated the literature. So just as a reminder of the stages of kidney disease, and we are going to be talking about today stages 1 through 5 in the adult patients, 18 and older, not on dialysis. So this doesn't even apply to dialysis. There are other guidelines in those bodies of evidence that I talked about that deals with dialysis. Our next stage is to go into dialysis and look at that literature. We felt that there was a lack of evidence analysis for those non-dialysis patients, is why we did this first. So this is the evidence analysis library that the Academy of Nutrition and Dietetics has, and there's the link to it. It is one of the most valued member benefits in our organization. So if you're a member of the Academy of Nutrition and Dietetics, you automatically get access to this just as a member. If you're not a member, there is a fee, and organizations have purchased it, but it is very valued by our membership. So we have seen definitions of evidence-based practice and showed them today for ICDA, and I actually was on that work group with them when we came to consensus. No, it was actually Pauline, sorry. I'm looking at you going, I was actually on that work group with them, and because this is our definition, and this is what is the basis for what you'll be seeing today. So it's the use of systematically reviewed scientific evidence in making food and nutrition practice decisions by integrating best available evidence, and that is the key. Pauline said that today too. This is the evidence we graded is 2 years old now. There is more information, unfortunately, and Pauline threw down the gauntlet. Unfortunately, there's not a lot of evidence in nutrition in any of those areas of specialty, and we all need to provide more, so we will have more information. And our goal is to improve outcomes. I said this before, so stages 1 through 5, kidney disease, not on dialysis, but also including those patients that have had a kidney transplant and how that might be affected by nutrition. So we looked at scientific evidence to support medical nutrition therapy in this population. The topics we included are listed there, and I'm not going to go through them verbatim, and because of the length of this presentation, I've not put down all the recommendations either. So this is the executive summary of recommendations. Behind these recommendations is the body of literature, how we made our decisions, etc. But you will find at the bottom of each of the slides whether or not the recommendation is rated strong, which means that there's a good deal of evidence. It may not be random controlled trials, but it may be meta-analysis, but good evidence. And then we go to fair, weak, and there is some consensus information. And what we don't realize now, I think, or remember, is when those practice-based guidelines started, a few years ago. The National Kidney Foundation ones were started in the early to mid 90s. The nutrition one for the National Kidney Foundation was done in 2000. You will see a lot of consensus because of lack of evidence. Now, does that mean that we shouldn't be using it? No, it means we should think about using it and perhaps see if there's any more information out in the literature to make that change. But medicine and nutrition has been practiced by the consensus of long-standing professionals for many years until we really have more studies. There may be some guidelines that say insufficient evidence too, and that just means we really need more evidence. Conditional at the bottom of our guidelines means that it's a specific situation, and then imperative means that you can do it across the whole target market. Again, I'm not going to go through those, but that is the many areas that we looked at in our literature review. And the Academy of Nutrition and Dietetics has practitioners who are specially trained in evidence analysis in the way that we do them. And so those people like myself, who was on this work group as content experts to validate what they were presenting to us, we didn't rate the evidence. Those are rated by people who may not know anything about renal disease, but know a great deal about how to rate evidence. So one of the first, some of these I'm going to go through rapidly because of my time, and I stole most of it trying to get my technology to work. But yesterday we talked a lot about how often you need to see patients. And the first recommendations we have really are about dietetic practice in this specific kind of disease state. So it is recommended that medical nutrition therapy is provided by the registered dietitian for individuals in these settings, and to prevent or treat the conditions such as protein energy malnutrition, the electrolyte disorders that happen with chronic kidney disease, and then to minimize some of the impacts of on comorbidities with kidney disease like diabetes. And from our evidence, the referral per MNT, and this says federal, it would be national guidelines if we go global, or there are state guidelines. Each of our 50 states may have some guidelines as how often to refer to dietitians. And it really should be at the initiation of the diagnosis of chronic kidney disease. So if someone is early on in their disease process and they don't have all those irregularities of electrolyte imbalances, doesn't mean they shouldn't see a dietitian, because then you can prevent some things from happening. And medical nutrition therapy should be initiated in at least 12 months prior to the anticipation of either dialysis or transplantation. And usually they are in then late stage 3, early stage 4, and then you have the greatest impact on their management. The physicians are managing with medications, we're managing with nutrition in hopes of decreasing the rapid progression towards needing of dialysis. And the frequency of that medical nutrition therapy in this population, depending on the nutritional status and other factors, should be every 1 to 3 months. So I can't really speak about other therapies in other diseases, but in this disease, because of what the evidence says, we have this information. And the last point down there is research as far as the time requirements indicated per month or up to a year, maybe the number of hours. It may be, it's not really determined the quantity. It really depends on what the patient needs. But you have to have enough interventions at the right time for the length of time for the patient to make any difference so that the intervention is effective. I've been in practice a long time, and that one referral by the physician for solving every problem a patient might have nutritionally is not really effective. Interestingly enough, in assessing body weight, we have so many different different information and ways to assess body weight. In chronic kidney disease, you as the practitioner need to use your judgment because there is no evidence to show that using actual weight or history of weight changes or ideal body weight or usual weight or a quick way to figure out a different way to do weight and underwater weighing, or if you wanted to. There's nothing that says one is better than the other. So judgment is used because you have to look at their measured weight. History of weight change may be the most important thing because they may be within their ideal body weight, but they've lost 10 kilos in the last 6 months. And always, for most every condition, a series of weight measurements would be important. Body composition, use any valid measurement you wish to do because there's really no reference standard for this in this population. That's what the literature shows us. Biochemical parameters, this was consensus and imperative. So it was a group of us, long-standing professionals, saying what we've measured over the life of our careers, and around that table was probably 150 years of experience. But there isn't any literature, any studies that say that measuring glycemic control on this amount of time, for example, will lead to this outcome. But glycemic control, we do know from some of the diabetes control studies that that's really important so you don't end up with the other conditions such as kidney disease. Bone mineral disorders are a significant problem in this population, and the dietitian should be assessing the parameters of that. Dietitians should be assessing medical and health history for adults, including their diabetes history, hypertension, obesity, and disorders of lipid metabolism. Adults with chronic kidney disease, even those after transplantation, have a higher risk for these comorbid conditions, and then it increases the risk factors for the progression of kidney disease. We try really hard with our transplant patients to get them to understand that that is a treatment for their chronic kidney disease and they aren't just now miraculously cured, and that their big management from a medical and a nutritional perspective is the obesity that happens with the medications, hypertension, diabetes. So we looked at what protein intake. Remember, these are not dialysis patients. These are patients that are going, that are approaching dialysis. And what we found in the literature was 0.6 to 0.8 grams of protein per kilogram of body weight. And there's some other literature we'll get to about keto analogs, which in Europe it makes some sense. It is difficult in our country to have people only eat the recommended amount of protein, which is nationally only 0.8 grams per kilogram. We eat way much more protein than that, particularly guys, gentlemen. And so in order to even get people to adjust down to what they need for their own body is very difficult. So it's a challenge. A client's motivation can make all the difference. Willingness to participate in frequent follow-up. And then you have to be careful because there's a small but significant population that will take it all to heart. And they'll reduce their protein intake, but they won't increase their other source of energy and end up with protein-calorie malnutrition. Now, in Europe, you have keto acid analogs. We do not have them in the United States. And there's strong evidence that you can reduce their dietary protein from 0.3 to 0.5 grams per kilogram of body weight if you use keto acid analogs, and as long as you get adequate calories so that you're protecting their breakdown of their own muscle mass or their protein. But in the States, it doesn't matter. We can't use those kinds of products because our government hasn't approved them. For diabetes, the literature, and it's only fair, it's not really strong, is a little more protein, but not a lot. When I started practice, we'd try to replace all that protein that they would be losing in their urine. And you have to see if that amount leads to hypoalbuminemia, which if it's diet related, that's one thing. It's because they are losing so much in their urine and you can't control that. It's another, but again, another reason to continue to carefully monitor them. For the kidney transplant after the surgical wound has healed, it really goes back to that recommended amount of protein that they need just to live healthily. Not going back to the regular amount of protein they may have been eating prior to the onset of chronic kidney disease. So it is using much more heart-healthy and not excessive amount of protein. And this was consensus and conditional because there isn't any literature that supports that. It's just a body of information by those of us who have followed patients for a number of years. Phosphorus should be 800 milligrams to 1,000 milligrams per day, or 10 milligrams to 12 milligrams per gram of protein they need. And I didn't convert it to European units. So I'm sorry, I have it on my computer how to go to that. Hopefully you have on how to go from the imperial way, I suppose. We use a considerable amount of binders to bind phosphorus intake, and the dosage and timing needs to be individualized and adjusted for phosphate content of meals and snacks, which is again what we are really good at as dietitians. An order for 2 binders each 3 times a day with meals, and a patient only eats 2 meals, so they don't take that much binder, probably is going to be ineffective. Or they eat really light breakfast and lunch and a massive amount of dairy products at dinner, and they haven't really matched their binders to it, so it's quite ineffective. Kidney transplant patients actually need more phosphorus, and so that's another role for a dietitian. Calcium, after looking, there's not much literature out there, except it's common accepted practice among nephrologists and dietitians who work with these patients, and we know that calciphylaxis or calcium buildup in soft tissue is a big problem in these patients, and so the recommendation is not to exceed 2 grams or 2,000 milligrams per day in total calcium in dietary, and if you're using a calcium-based binder. Also, this is practice, and they're in here, and again, it's consensus about the amount of iron based on some parameters that the U.S. has established in those KDOKI guidelines that we use. And then the need for B12 and folic acid in patients that don't have iron deficiency anemia but actually have, their MCV is high and they've got macrocytic anemia. And oftentimes with the dietary prescription that we use in these patients, they aren't getting enough B12 and folic acid because we're trying to control their potassium, phosphorus. The recommendation for diabetes management is to achieve a target level of an A1C of approximately 7%, and that's pretty acceptable around the country, around the world. KDIGO's also has that. And if we're talking about the dyslipidemias in these population, the recommendation is to use a multifaceted approach, which is a lifestyle change approach, which is diet, exercise, and medicine if necessary. If patients aren't seen by a nephrologist and a dietitian that's comfortable with these recommendations, oftentimes it is medication initially. And there are some significant side effects with those medications, which are quite effective, but diet and lifestyle need to be tried first. Sodium intake, the evidence is fair, and what we found was about 2.4 grams of sodium should be the maximum amount for all the reasons that come with chronic kidney disease. Our government just came out with dietary guidelines that actually in this population would drop it down to 1.5 grams of sodium, and they are aspirational. In the U.S., sodium intake is usually 4 to 6 grams, and if you can drop it at all, it's going to be helpful. Potassium intake, we often see, and we were talking a bit about that yesterday, see that a low potassium diet is put on someone when there's no indication for it. If serum potassium levels are normal and a patient is urinating adequately, particularly in early stages, they can have more potassium. And particularly if they're using a diuretic, then it's contraindicated to put them on a potassium-wasting diuretic, such as Lasix or hydrochlorothiazide. It's contraindicated to put them on a potassium-restricted diet and then give them a potassium supplement. I've seen that. Patients going, why do I have to do this? And it is not looking at the whole picture. But oftentimes that happens. Things that make a huge difference in potassium in this population is acidosis. In pediatric nephrology, which I've worked in years, we were very good at recognizing if somebody's serum bicarb was too low, the kids were not going to grow well. In adults, we didn't pay all that much attention in the United States to probably about 5 years ago. And now there's a big push to correct acidosis caused just because of kidney function, their acid base ability is diminished, or because they have diabetes and they're so hyperglycemic that they're acidotic. If you correct acidosis within the normal range with early chronic kidney disease, their potassium is likely to normalize too. Glycemic control is imperative, and we don't want catabolism to be happening. Planned weight loss is great, slow planned weight loss, but if somebody is losing, as I said, 10 kilos in 6 months, and that's pretty rapid, and as your body muscle mass turns over, it's going to increase your blood urea nitrogen, but it's also going to put a potassium load, because most of the potassium is intracellular, not extracellular. Oh, and constipation. If a patient is constipated, their potassium is likely going to be elevated too, and fix that and it's probably going to help. So that's why you have to look at the whole picture, as we've been talking out. So online in our evidence analysis library is all online. We actually have an algorithm kind of process where you would go through and look up the different disease states, and we've divided it out into that nutrition care manual and using that standardized language, which I talked about before. So within these guidelines, and there's a fair number of them, have diabetes, we have chronic kidney disease, and I can't think of the rest, but there's a fair number of them. Our membership said, these are fine and dandy, but how do we really implement them? So we have developed a number of toolkits, and the chronic kidney disease toolkit is in process. But it will have an overview of chronic kidney disease. It'll have some documentation forms for those dietitians knowing what to look like. So taking those recommendations, putting them into practical steps. We'll have outcomes monitoring sheets, education resources. So that was my part of the toolkit. I looked up every website I could and put it out there. Some case studies, how to implement it, and then the protocol for treatment. And they're electronically downloadable. There's a small fee for them when they're there. So you might, if you even go on the evidence analysis library, you can get to that website and download those toolkits for really a nominal amount and put them in their electronic. And here's the website, www.andevidencelibrary.com. I'll leave it up for a second while Gigi comes up. And if I talk too quickly, I apologize, Christian. Okay.